Next up, we have Angelica Tobias from the Baylor Scott and the White Heart Hospital, Plano.
Good afternoon, everybody. Before I start, I want to give a shout out to those guys over there because I didn't realize I sent a blank PowerPoint, and then when I tried to review my slides last night, it was blank. So you just imagine my stomach and everything blood just drained. And so they helped me today, so thank you guys. This is my EBP project, and I work at Baylor Scott and White, the Heart Hospital, Plano. Just a background about me. Yesterday, we heard from the keynote speakers about nurses from different countries. I was one of those. So I was hired 20 years ago. So this recruitment agency came to the Philippines and hired a bunch of nurses, and so I was one of them. So I'm a testimonial that your retention rate is really gonna stay, because most of the nurses that I came with, they're still in the hospital 20 years from now, like 20 years ago. So they're still there. I did jump to a different hospital. I stayed in the same state, but I jumped to a different hospital only because I realized I can only do hearts. I'm not good with neuro. I'm not good with OB or ER or trauma. I cannot do blown off hands, nothing like that. So I concentrated on just hearts. So Baylor Scott and White is over 100-bed hospital located in Plano, Texas, and we only do hearts. We do hearts, heart and lungs, heart and vascular, but mostly heart failure patients, mechanical circulatory support devices, heart surgeries, and things like that. So my EBP project is enhancing post-cardiac surgery resuscitation, implementing the Society of Thoracic Surgeons guidelines for improved outcomes. Oh, there you go. So the challenges for post-heart surgery patients is whenever they go into cardiac pulmonary arrest. Everybody tell me, you did your BLS, you did your ACLS, the first thing you do when you see the patient down is, hey, are you okay? And then you jump on the chest and then you just start chest compression. It's not good for heart surgery patients who has had sternotomy, with valves or with new grafts, and that's not really good. And then now, part of the guidelines is you have to give epinephrine within, 3 minutes when the patient is down. For heart surgery patients, you don't give a full dose. So you can only give a little dose, but not a full dose, because then you'll blow off the new grafts or the new valves. So, AHA has been very vocal, or whenever they publish these new guidelines, they're very specific about doing a little catered to cardiac surgery patients. And so with pregnant women, you don't do the regular ACLS or BLS on them. They're specialized care. So there is limitations on recovery for heart surgery patients. So these are the challenges. The post-cardiac arrest challenges, the standard ACLS protocols often are inadequate after cardiac surgery. So there are unique reasons why patients go into cardiopulmonary arrest after heart surgery. Most of the time it's bleeding or electrical activity, so that's your VFib or VTAC, but most of the time it's tamponade. So timely intervention is critical, and seconds do matter. So what STS is saying is that you can take a pause for a minute and not jump on the patient's chest, so that you prioritize defibrillating your patients over jumping on the patient's chest. So if the patients go into VFib or pulseless VTAC, your priority is to shock them. So not to jump on the chest or not to give a full dose of epi. If you do need to give epi, just give a little bit of the epi. So our epinephrine in our hospital is 1 milligram per 10 ml. So our doctors would usually say just give 1 or 2 ml, and then that's it. Because they're very careful about the consequences of you giving a full dose of epi or doing chest compressions. So you shock them, you try to switch them back into regular rhythm. If not, then you shock them again. If not, then you shock them again. That's the STS protocol. So it has been established since 2017. AHA has been saying that cardiac surgery patients need to have a specialized, process. But really, it wasn't until 2017 that the Society of Thoracic Surgeons published the article about the step-by-step. So now we have the Lucas devices, the mechanical chest compression devices. STS said no to those. And I think now the AHA guidelines, the most recent ones, is saying that you only use the mechanical compression devices only if you need to. So before they were advocating for it, but I think now the guidelines is saying no unless you're traveling and somebody has to be like doing chest compression while you're traveling. So anyway, evidence-based need for change. The Society of Thoracic Surgeons recommend defibrillating or pacing if your patient goes into symptomatic bradycardia. You don't give atropine. They said completely, definitely no to atropine. You do have pacer wires for patients who come out after heart surgery. So you just pace them, you don't use atropine, or if they don't come out with any pacemakers or pacer wires, then you just put the transq pads and you start pacing them. So, and then internal massage over external cardiac massage. So our hospital, since it's an entire heart hospital, so every unit has an open chest cart in the unit. So our rooms can convert to an operating room within seconds. We do have operating room nurses 24/7, and 2 of them are always on standby. So even on nights, if they hear a code blue, it doesn't matter if the patient is post-op or non-post-op. Once they hear code blue, they have their carts and they come out and then they just go to the rooms. They're ready to assist whenever. We do have also an ECMO program. I'm an ECMO specialist over at the Heart Hospital. And so if, let's say the patient is not, they cannot open the chest, our physicians can activate the ECMO team. So why does this matter? Because if you do specialized guidelines for post-heart surgery patients, their failure to rescue rates, they decrease. So when I did this evidence-based project, we compared resuscitating patients using the ACLS versus resuscitating patients with STS. And 100% of the patients that we used the STS guidelines, they all went home within 10 days. And so the ones who were resuscitated after ACLS, they actually stayed in the hospital. The longest time was about 56 days. So this is the problem. If you want to look at the STS guidelines, it is the STS 2017 on resuscitating patients to arrest after cardiac surgery. So the study design, analysis of post-cardiac surgery arrests. Actually, it's January to September 2024. I concluded it in January 2025. So 20 patients analyzed after exclusions from LVAD, TAVRs, post-op day, more than day 10, and the respiratory arrests. So the groups that were studied is the standard ACLS. We do have 17 out of the 20. And then the STS guidelines, we do have 3 out of the 20. So the outcomes that were measured is survival to discharge, neurological outcomes, time to ROSC, length of stay, and the need for additional interventions. So for the ACLS group, 10 survived to discharge. Several required additional surgeries or large volume blood transfusions because when you do ACLS on post-sternotomy patients, the highest risk is those sternal wires puncturing the heart or the valves are blown, and so they would 100% bleed. So we will see their chest tubes that would start draining profusely, and then they always end up going to the OR. So the length of stay ranged from 10 to 56 days. The neurological outcomes were mixed. As for the STS guidelines, the 3 patients, all 3 survived and were discharged home. 1 patient actually walked out of the hospital, refused a wheelchair, and that's just to prove to everybody how wonderful care that we did, and he went home in 9 days. So there were no further surgical interventions that were needed. Hospital stays were significantly shorter, 6 to 9 days, and all had favorable neurological outcomes. So the discussion here is the STS-guided resuscitation showed higher survivor rates and better neurological outcomes compared to standard ACLS. They have significantly shorter ROSC versus the ACLS. Shorter hospital stays with fewer additional surgeries or blood transfusions or therapies or surgeries. Current ACLS protocols may miss key reversible causes unique to post-cardiac surgery patients. So, you know, with your ACLS, you think about your H's and T's. So when you're resuscitating patients post-cardiac surgery, you don't have time to know what are our H's and T's, and then your patient is like, so instead of just like shocking right away and you convert them to normal rhythm. And plus, when patients come out of heart surgery, they all have these invasive lines. You have your SWAN, you have your EKG. It's so nice to be an ICU nurse because you all have like all these invasive lines. Your EKG, your pulse ox, your SWAN, everything goes flat. You don't have to do like, hey, are you okay? You just look at the monitor, everything says flat, your patient is flat. Then you just proceed your resuscitation. So everybody thinks like ICU is scary. No, ICU is great because everything is handed to you like you're being spoon-fed, right? So anyway, implementation of STS guidelines can reduce failure to rescue rates and improve overall patient outcomes. Support is needed for specialized resuscitation protocols in cardiac surgery units. So the key takeaways for this is STS resuscitation protocols led to higher survival and better neurological outcomes, shorter ROSC, and fewer surgical interventions. Standard ACLS does not address post-cardiac surgery arrest effectively. If you do read the guidelines, it just says you may need to adjust your resuscitation for cardiac surgery patients and pregnant women. I think it's just in parentheses. So you go to STS, and that's where it's like really laid out for you. Recommendations: you implement the 2017 STS resuscitation guidelines, and it's effective for post-op day 0 to day 10. So most of the questions I've received is, what if they're post-op day 11 or day 12? So it's up to your physicians to proceed, how to proceed with this patient. So we do discharge our patients after day 5, so post-op day 5, they're already home, but some of them, they do come back. But some of them, when they do come back, they're in cardiogenic shock, and then sometimes they do code. So then it's everybody's responsibility to know what post-op day that patient is, and then from ER to the units, they know what to do. Provide targeted training for ICU, surgical, and code teams, establish protocol triggers, monitor outcomes, and adjust as needed. So what have we learned from this EBP project? There's a lot that we learned on the EBP project. One of the major things that we learned is evidence-based is right there. And we need to apply it because it's evidence-based. But you need protocols, you need the support of your admin, you need the support of your leaders to actually establish those protocols. And that was the hindrance why I only got 3 patients out of the 20 to follow the STS because everybody is afraid. We use Epic in our hospital, and our Epic documentation is suited just for ACLS. So if they don't give the epi within 3 minutes, they are flagged. And then I don't know if they're pulled in the office, why didn't you give the epi within 3 minutes? So the nurses are afraid of that because they would have a fall off on their documentation. It's mostly documentation. And then, of course, their documentation is, not within the goal. Then it reflects on the unit. So then everybody is afraid to, maybe not ruin the name of the unit, but have a red mark or a red flag on their units. So that's the number one hindrance. So then when I started this project and I learned most of the nurses know about the STS guidelines, they're just afraid to follow it. So only because of the protocols and the documentations that's behind it. So present findings for cardiac surgery. So I did that. I presented the findings to cardiac surgeries. Everybody is very supportive. My CNO, our CNO is very, very supportive. She was like, let's do it. And then when some of the doctors, when she would have pushback from the doctors, she'll be like, no, the nurses are right there 24/7. And so our CNO is great. Proposed formal adoption of the STS resuscitation protocol in postoperative cardiac units. Identify champions from surgery, anesthesia, and critical care teams. I have discussed this with our local Code Blue committees and the system Code Blue committees. And then on top of that, I've presented this project over to our system cardiac surgery committees. And everybody has been very much supportive. So what we're lacking right now is an actual protocol in the hospital wherein the nurses can pull up from our policies and procedures. Everybody is already aware, we just don't have it in black and white in our policies. Develop and publish the standardized STS protocol. Ensure availability of emergency sternotomy kits in key locations. So every unit in our hospital has this open chest cart. Because like I said, every room can transform into an operating room within seconds. But we do have this big metal instrument kit that has 10 million instruments there where if a nurse opens it, they're just, they get scared. So the manager for surgical instruments in our operating room, she devised it, she compressed it into just these 5 initial instruments that the nurses or the doctors will need to use. And it's very easy, so she laid it on top of the cart. So if any of our patients goes into cardiac arrest, they can just grab that metal kit and then the whole cart is to follow. So within seconds, they can open the chest at bedside. So ensure availability of emergency sternotomy, evaluation, monitor for failure to rescue rates, collect feedbacks from clinical staff, and re-edit outcomes in 6 to 12 months post-implementation. So we're still in the process between the early implementation and implementation. But we're slowly heading there because we are a system where our hospital, I think it's over 40 hospitals in Texas. And so it has to be not just for one hospital, it has to be system, applied system-wide. So, and these are my references. Thank you, guys. Any questions? No? Oh, thank God.
Sorry, I'm going to ruin this.
Oh, no, you're good.
You were saying that most of your nurses, thank you. You were saying a lot of your nurses are aware of your STS protocol, but they're afraid to follow it. Is there a talk, are you also in discussion with your Epic IT team to build the appropriate build? Because I know that's one of the things that my hospital has run into. If it's not an Epic, right, we can't document it, so we can't build it. So since you're in the early implementation phase, can you talk a little bit about how that discussion has gone?
Yes, thank you for that question. I forgot to mention it. So The STS guidelines, so there is a team of nurses, physicians, and perfusionists that goes to the hospital to train the nurses, just like AHA, that's like teaching, ACLS and BLS. So there is a separate organization that would come to your hospital to teach open wrist sternotomy or open chest compressions or emergency, ACLS for cardiac surgery patients. So if you go to their website, it is called CARE, C-A-R-E, or you search for CSU-ALS, or more popularly known as CALS. So we've adopted the name CALS before, but then now CALS is used in Europe, and CSU-ALS is used in the USA, but it's the same. So it's a combined, not effort, but combined research from Europe and USA. It's just Europe calls it CALS and US now calls it CSU-ALS. But if you go to their website, it's CARE. So when we reached out to them, they offered us to build our EPIC specifically for post-cardiac surgery patients. Because when I presented this for the system, one of our IT actually asked, like, okay, so you've seen this hindrance, you've seen this pushback from your nurses, how can we fix it? But they don't have like a starting point. Mm-hmm. So then when we reached out to CARE, they're like, oh, we can help. Just let us know when, and then we'll come to your hospital, we can help. Like, wonderful. So that's how we're gonna start. But for right now, we're starting with the protocols first. In that way, the nurses are not afraid, because we can put in like specific orders, like epi, just 1 or 2 cc's, like just individual orders, not part of the code documentation yet. So I think it's one step at a time for our facility, but we're heading there. Thank you for the question, though.
I have a follow-up if no one else has one.
Yes.
Okay. And is there also discussion about making this, so I know ACLS, right, we have those code orders that become, it's like a standardized order set, so the providers just have like one and it's done. Is there also discussion about making it a standardized order set as well, once you have it built, so that it's easier for the providers, but also your nurses, right, so that it just falls all right there?
Yes, once the team comes to the hospital and we do they do the EPIC build for the CSU-ALS, they would also help us establish the order set for those, and it's going to be built in the code documentation. And what they told us, it's going to be 2 separate code documentation now, code documentation for ACLS and then code documentation for the CSU-ALS.
Perfect. Okay.
So
Thank you so much.
you're welcome. Thank you, guys.